Well, good afternoon, everybody. Welcome to the final portion of this weekend's Osler course. I hope you all found the uh, first few days helpful. I know it's the last session. So what I wanted to do was really keep it high yield. So I'm not trying to give you all an Astro refresher course. I really want to focus on things that I think will be most relevant as you take the written exam. I may throw some tidbits in for the oral exam in as well. As we go through the slides, I've highlighted in red things that I feel are the most high yield. And I've gotten this off of reviewing my residence notes, questions, and from educational sessions we've done previously. So again, the concept is to really try to make it as high yield as possible for you all. So I am a professor at MD Anderson and want to thank my colleagues, Dr. Swanson and Dr. Tang, for use of their slide deck that really provided the framework for this afternoon. I'm going to start with the highest yield stuff first. So low risk, intermediate risk prostate, then high risk prostate, oligo and / metastatic prostate. Then we're going to move into adjuvant / salvage therapy in prostate, then bladder / testes, and then the low yield stuff, kidney, ureter, urethra at the end. So generally speaking, when you approach any case, you want to diagnose first, then stage, then treat, then follow up, and then manage the side effects. So the biggest problems I see when we administer mock orals to our residents is that there is a tendency in the excitement and pressure of the oral to jump straight into treatment. I'd advise you all to just take a deep breath, stop, and just follow the rubric here. So diagnose first, then stage, then treat, and then you can talk about follow-up and managing side effects. If you do that, that'll keep you on track. If you reiterate the case back to the examiner, that will also allow you time to think about what you want to do. And also, if you've heard it wrong, that'll give them an opportunity to correct you so you can get back onto the right track. I'm going to use this framework in our written lectures as well. So for prostate cancer, the diagnosing starts with screening. The current recommendations from the AUA is that patients and doctors should have shared decision-making. A PSA or DRE should be done every 2 to 4 years for people age 50 to 69. For those who are 40 to 45, you want to screen if they are at higher risk. So Black ancestry, germline mutations, strong family history. The most common germline mutation, remember, is BRCA2 and then ATM. So they like to ask that. The U.S. Preventative Services Task Force changed screening and now recommend screening for 50 to 69 as an individualized decision, and they are against screening for 70 and up. The take-home messages for screening are that screening does reduce prostate cancer-specific mortality. It does reduce disease progression, but this comes at the risk of over-detection and over-treatment. There are 3 trials that looked at screening, ER-SPC, the CAP trial, and PLCO, that I'm going to touch upon briefly. Before we do that, I want to go over the endpoint usage. So you'll see more modern trials using metastasis-free survival as endpoints versus the biochemical relapse-free survival that they used to use, because MFS is a stronger surrogate endpoint for overall survival in localized prostate cancer compared to biochemical relapse-free survival. And that's because it captures the development of distant metastases, which then correlates better with overall survival. So using MFS, the feeling is that it could allow for faster evaluation and approval of new therapies, and it's a stronger predictor of overall survival benefit. So keep that in mind as you evaluate new trials. The ER-SPAC, which was published in the New England Journal in 2009, randomized over 150,000 men to either observation, and they biopsied only if PSA was greater than 3 or abnormal DRE, or they screened using variable practices between 2 to 7 years and had the same triggers to biopsy. They showed that the in-group screening rate was 82%. The in-control group screening rate was not reported, but believed to around 20%. And then the 9-year incidence of prostate cancer deaths was lower in the screening cohort versus the control group, and that hazard ratio was statistically significant. On the update, this also held true with a much lower rate of prostate cancer deaths in the intervention group compared to the control group. The CAP trial was done in the UK, and it randomized to screening with a single PSA in clinic versus to not screening at all. If PSA was greater than 3, then they did a 10-core biopsy. The CAP trial showed that screening improved both detection of prostate cancer as well as prostate cancer deaths. The PLCO trial looked at US men, ages 55 to 74, randomized them to usual care. The triggers to biopsy were PSA greater than 4 or abnormal DRE. And then on the other arm, they did a PSA test every 6 years and DRE every 4 years. And then the triggers to biopsy were also PSA greater than 4 or abnormal DRE. They found that screening diagnosed more prostate cancer. There was no difference in prostate cancer deaths. And in the screening group, the screening rate was 85%. In the control group, however, the screening rate was also pretty high at 52%. So at 17 years follow-up, they did show that the number of deaths in each arm were roughly the same throughout. But that's because the screening rate was higher in the observation group. The other thing that you may notice is the use of 5-alpha reductase inhibitors. So there are 2 trials that looked at whether these can prevent cancers. This is the PCPT trial that used finasteride, or the REDUCE trial that used dutasteride. The cutoff PSA was men with PSA less than 3 were randomized to treatment versus placebo and then followed. Now remember that 5-alpha reductase inhibitor suppresses PSA. So when you see somebody with a PSA of a certain value, you want to remember to roughly multiply by 2 to give you the rough corrected PSA. And these trials found that the risk of prostate cancer was reduced in those men taking the 5-alpha reductase inhibitors, but that was because they reduced the lower grade cancers. Please remember that. Now, when diagnosing prostate cancer, the active surveillance trials use greater than 3, some use greater than 4 as a biopsy trigger. But there are other methods to sort of tease out when you should jump in for biopsy versus not. Now, you don't necessarily need to know the details of this, but just be familiar with the things I have in red over here as part of a multiple choice question. So free PSA, the lower the free PSA, the higher the risk of cancer. PSA velocity, so greater than 2 nanograms per ml per year predicts increased risk of death. PCA3, which is a urine test, and then the 4K score, which is a blood test measuring kallikrein. So that increases the probability of finding a Gleason score greater than or equal to 7. Now, this is important because the mainstay of staging really is PSA elevation. DREs can be used and have been used historically, but they're not very sensitive. So most of these organizations recommend that you should not use DRE by itself. It should be used in conjunction with PSA. Looking at prostate cancer biopsies, once you've made the decision to biopsy, the traditional methods include a truss, which is a random biopsy of 8 to 12 cores. But now, more frequently, we're using MRI-guided biopsies, which have shown to improve detection of clinically significant cancers, and then the added potential of using less cores. So 2 trials looked at this that I want to go over briefly. First, before we go over that, I want to go over Pi-rads. Now, they may ask you to point out where an abnormal finding is on an MRI. So you want to do that using really the T2 weighted MRI on the side. So the T2 will show the peripheral zone as a whitish sort of area. I'm going to point that out right over here, a whitish sort of area. And this, in the middle of the white area, you see a big black spot. So that's suspicious. Now, Pi-rads will take T2 images and also compare them to diffusion weighted imaging, as well as dynamic contrast enhanced imaging, and assign scores, and ultimately give you a Pi-rad 3, 4, 5, etc. that will suggest doing a biopsy. But here you see that nodule that appears abnormal on T2 also